Thank you for inviting me. It's a pleasure to be here. I'm going to be talking about a vision for our healthcare future and an entrepreneur's perspective on some of the barriers and some of the solutions to the barriers that have sort of prevented us from achieving this healthcare vision. To start off with, I just want to note that I have no disclosures at all. I do have some relationship with ScribeLink, but they're not a supporter of this activity at all. I do want to tell you a little bit about myself. I can see I'm sort of in the similar range as a number of the physicians here in terms of age. When I started practicing, the treatment for an acute MI was bed rest. It's about a week of bed rest. And the people who had a cholecystectomy stayed in the hospital for about 10 days because they had a half chevron incision. It was before Lipitor was invented. It was before electronic health records. It was actually before dictation. I remember when dictation started up, and all the physicians were really opposed to it because it was like disrupting their care of patients. For the last 20 years or so, I've actually been an executive officer with a fairly successful group. We've grown since I've been an officer from about 100 million in revenue to about 1.4 billion in revenue, and that's all organic. That is not from any mergers or acquisitions of other groups. It's purely from our own internal growth. During that period of time, I've been responsible for creating most of the programs and innovations. I was actually the first chief medical officer and the chief innovation officer for the company. And so I've had the opportunity over the last 20 years to oversee an enormous number of different programs, some of them fairly well nationally recognized. In fact, if you look up things like rapid medical evaluation, that was actually a trademark term that we created because we were one of the first people to sort of re-engineer emergency department flow, but now it's like Kleenex. Everyone in the country uses it. And quite a lot of other programs, as well as the adoption of all types of technologies, everything from point-of-care testing. We're a multi-specialty group. We're primarily hospital-based, and so there's a lot of different technologies, the implementation of electronic health records, all the new drugs that have come out to the market, as well as new practice lines. We have all types of telemedicine practice lines. We're the nation's leader in putting in place crisis stabilization units, psychiatric emergency departments. So I wanted to provide you with my perspective from an entrepreneur's vantage point. I know most of you are entrepreneurs, and an entrepreneur is actually someone who creates programs within an institution versus an entrepreneur who's starting out their own company. We still create programs, but the main difference that I can tell between an entrepreneur and an entrepreneur is this. As an entrepreneur, when you're successful, you get to go out and buy your own private jet, your own yacht, maybe go to the polo games. As an entrepreneur, after a lifetime of creating programs, you might be able to buy a set of skis and a bicycle and maybe even your own MMA gloves. Those are actually custom embroidered though, so that was an extra couple $100. So, about 4 years or so ago, I wrote an article where I used the term medicine without walls to describe the vision of where healthcare is heading. And I meant that both figuratively and literally in terms of where healthcare is going. We are hopefully, and I believe we will, approach this vision where any person can obtain any type of care anywhere, at any time. And it'll be as efficient as it can be. It'll be up to date because of the information transfer that occurs that allows us to create the most advanced algorithms that are used by every clinician everywhere for every specialty. That's in a nutshell the vision. What would that vision look like? Well, I would imagine you would have hundreds of millions of individuals all on the same cloud-based AI-supported platform. It would connect thousands of hospitals with tens of thousands of pharmacies and tens of thousands of clinics. Because there's perfect information transfer, what we would see is that the care algorithms are AI supported. Care is able to be triaged appropriately. You would, if you had a certain level of care that you needed, well, you would go to a specialty clinic and you would see a specialist. If you needed a different level of care, maybe you'd see some type of advanced provider in a clinic. Or maybe you just see a chatbot in some type of environment, either your own home or a specific location that you went to. And it would not only include your payer, it include the provider, and you could see providers anywhere, and it also include the pharmacy, so your scripts were automatically sent there. And because you had all these hundreds of millions of patients involved, where you could create very sophisticated algorithms. We have a teleneurology program where we have one neurologist on for 25 hospitals. You could do that across the entire spectrum of healthcare. Imagine if you could do something like that. What would you call it? If you could provide free medical care in poverty-stricken areas and rural health care where you don't have clinicians. Well, I'd call it Ping on Good Doctor, because that's the system that already exists. I'm not sure if all of you are aware, but Ping on Good Doctor has 300 million individuals on their platform already. And they're looking at contracting with Southeast Asia for another 200 million, and with Japan for 150 million patients. That's 750 million patients on a single cloud-based AI-driven platform. The future's now. It's just not evenly distributed. When did they start? Actually, they started when I wrote that article. They just started 4 years ago. In 4 years, they've gone from a startup company to a company with 300 million users. Imagine that. 300 million users. So, is that going to happen here? I'm a total optimist. Absolutely. In fact, this is a blog I wrote recently. Advances in technology will revolutionize healthcare. There will be no endpoint. Absolutely. Absolutely. Here's the thing about technology. It doesn't matter what technology you look at in this world. Any technology that creates a value proposition eventually distributes globally. It can be toothpicks, it can be bicycles, it can be cars, it can be jet planes, it can be dams, it can be roads, it can be assembly lines, it can be nuclear power plants. There is no technology that doesn't eventually distribute globally if there is a value proposition. So will we see this here? Absolutely. Absolutely. But when we look at care in this country, a lot of you are entrepreneurs, and you probably look at care and think, this is the decision-making process that occurs in our healthcare system when we're looking at a new technology. Here's a group of stakeholders and their conversation about whether they should adopt a new technology. Should we adopt this new technology? I say we hire a consultant to convene a needs assessment team. I can't review any data until after my trip to Bali. Perhaps we should wait and do nothing right now. I don't care for emo rap. Can someone switch the station to soft rock? I'm hungry. I wonder if the cafeteria has pie. Okay, let's regroup in a couple months and discuss this further. That is probably the experience that every one of you that's an entrepreneur has faced or felt that you faced when you were trying to present your new technology, that these decisions were taking forever, that nobody was being responsible, that nobody was moving forward with your technology, which every one of us probably thinks contributes to healthcare in some significant way. And we wonder, why is technology adoption so slow? Here's the thing. There's actually almost no industry where there's a greater reliance on technology than healthcare. Robotics, bioengineering, genetic engineering, all these types of telecommunications, data analytics, the amount of technology that goes into healthcare is truly, truly phenomenal. But here's the other thing. Healthcare in the US is an enormous ship, and it takes a long time. There's an enormous amount of inertia, and I'm going to talk about inertia and the impact on our adoption of technologies. There's an enormous amount. So when you look at industries, the electronic digital computer industry, the first digital computer was built in 1943. In 2018, the revenue from all desktops sold in the United States was $10 billion. The first commercial flight occurred in 1914. The entire aerospace revenue in 2018 was $760 billion. The first auto was built in 1885. In 2018, again, another two-thirds of $1 trillion, three-fourths of $1 trillion. The telephone was invented in 1876. In 2018, about $60 billion. The practice of medicine has been around since 2000 BC, 4,000 years. It is a $3.7 trillion industry. In other words, all these other industries around for less than 150 years, the total revenue generated by all those industries is less than half of healthcare. Healthcare is an incredibly old and incredibly large institution. You can't change it as fast as some of these other industries. It has a structure that has been developed and a system of practice that's been developed for thousands of years. And there are trillions of dollars at stake in how we change our healthcare industry. So, a lot of people actually think healthcare is very inefficient. I know something like 70%, I understand they did a poll yesterday, 70% of the people in this room are physicians. Healthcare works perfectly based on the incentives that are in place, okay? I'm not saying healthcare industry is inefficient. What I'm saying is the way it functions is purely based on the incentives that are in place so that it is structured to function as the way it does. What I'm going to talk about is achieving our vision and how we get from our present care to our future care. And first I want to talk about some of the barriers that exist. Incentive misalignment, stakeholder bandwidth, fragmentation, delivery system ataxia, inertia, security, and privacy. I'm going to discuss each one of these briefly because I know all of you are already familiar with it, but sometimes we need to look in the mirror and get a better picture of ourselves to see what some of these issues really are that are facing our industry. The first is incentive misalignment. I'm not going to go obviously into significant detail on all these, but here's just one example, the entire opioid crisis. Any physician in this room can remember not more than 15 years ago where pain was the fifth vital sign. The Joint Commission published a guide that said some clinicians have inaccurate and exaggerated concerns about addiction. This attitude prevails despite the fact that there's no evidence that addiction is a significant issue. That was not long ago, okay? When every patient experience survey in this country was looking at how fast did they relieve your pain. Most of the CEOs of hospitals in this country were incentivized based on the scores that they received from how fast they got narcotics. In fact, we were scripted, we were taught to tell patients, we have more pain medicines than you have pain. Think about that. It's not a wonder that we end up with the opioid epidemic that faces this country. We need to look at how these systems develop and the incentives and how they're aligned within the healthcare system. And this is just one example of an incredibly large number. I mean, you guys probably have dozens. The second, bandwidth. 44% of all physicians in this country say they're burnt out. Think about that, that's phenomenal. Almost half of the clinicians, physicians in this country say they're burned out. This article was just in Yahoo. It's an alarming trend. Nurses apparently have one of the highest suicide rates of any specialty, of any group of healthcare providers in the United States. Their burnout rate's significant. CIOs and CTOs are way too inundated. There's a constant revolving door of hospital CEOs in this country. They move from job to job on a regular basis. We have an industry where, regardless of what kind of inefficiency we think exists, the people that are involved in that industry, to some reasonable extent, are working to their absolute hardest, where there's a significant amount of burnout. How do you impact and affect change in a system where you are dealing with a significant, because it only takes one naysayer when you're trying to put in place something new, and it slows things down significantly. And actually, I was at a conference this last year, and there were some hospital CEOs talking. They said the number one thing that was inhibiting them from putting in place new programs was physician burnout. Because they're just too tired. Nobody finishes a long day and has someone come up to them and say, hey, why don't we start a new project? There's an enormous, this is an issue for our healthcare industry. Fragmentation. Everyone is totally aware of healthcare fragmentation in the United States. Every system's a different system. Physicians don't work for the hospital. They actually have totally different goals than the hospital does. Payers have totally different goals than the health systems that they're contracted with. Everyone has different objectives. Health systems are competing against each other. In healthcare, when you've seen one, you haven't seen them all. Actually, when you've seen one, you've seen one. And when you're selling your product, when you've sold one, you've sold one. When you go out and create your product and you try to sell it on the market, your first customer is the absolute hardest. Why? Because nobody wants to try something new. Actually, your second customer is only harder because they don't care about that first customer, and they are less of an early adopter than your first customer was. It's just a system where everyone is totally fragmented, nobody's talking to each other, they all have different goals, and just because you have something that comes to market, the next person isn't more likely to want it than the first person. Next, health system ataxia. I'm going to do this through an illustration. You've created a new product, say a robotic arm, and you want to sell that, you're person A there, you want to sell that robotic arm to customer B. You start down your business development path, and this robotic arm, surgical arm, significantly improves patient outcome. It is more accurate, it's better than anything that's ever been invented. Patients do much better if they had surgery and you've used this robotic arm. Well, the patient, the beneficiary of your technology, isn't the user of your technology. The surgeon is. So you go to the surgeon, but the surgeon who uses your technology isn't the purchaser. The hospital is. You go to the hospital. The purchaser of your technology isn't the decision maker. Those decisions are made by some regional office, some corporate headquarters for that health system. Well, you go to the corporate headquarters, nobody tells you who the decision maker is. Is it the COO? Is it the CTO? Is it the CMO? Who is it? Who is it? You can't find that person. Then when you think you found that person, they need the input of numerous unnamed stakeholders, all these surgeons across their organization that have political influence. I know just by looking at you that you're agreeing with exactly how this is how healthcare occurs. And then, if you ever figure it out, every customer is going to be unique and completely different in their approach than every other one. There is such incredible ataxia in the healthcare system that just the way you have to maneuver and negotiate to get your product is incredible. Inertia. Inertia is maybe the most important. I mentioned it earlier, but inertia is so incredibly important. What do I mean by inertia? I'm looking at everyone here, and I'm guessing that if you're like me, you've never sat in this room before. We'll all go out and break, and probably almost every one of you will come back and sit in the exact same chair. Think about that. Every chair here is the same as the chair next to it. I can tell. There's no difference almost whatsoever. Okay? That is human behavior. That's inertia. We don't like change. Even simple things like walking into a room and that's my chair. You can take everything with you and you come back. It's still your chair. Okay? Let me tell you about my neighbor and my daughter. My neighbor is a hand surgeon, my next door neighbor. He went through 4 years of college, 4 years of medical school. I think he did like a 6-year surgical residency, a 2-year hand fellowship. And he did a 1-year special microvascular plastics fellowship, 17 years of training. So he could put 3 stitches in someone's hand tendon. My daughter graduated from college a couple years ago with a degree in communications. She wanted to be a novelist, and she was writing for a paper, but she really needed to make money. So she wanted to get a job, got a job with Facebook. They said, well, do you know how to program in this visual communications language? And she said, yes. And she went home that weekend, studied it on the internet, came back the next week and said, yep, I know the language. Started at Facebook. Very different cultures. Which group of people, these physicians who are willing to spend 10, 15 years training to do work, or a group of people who do things after a 3-day course or none, which group of people do you think has more inertia? Because all of us have a different amount of inertia in our lives, but culturally, which group of people, the group of people who are willing to spend 15 years training to do something, or groups of people who come out and every other day say, okay, I'm going to do something new, and I'm going to take a course to learn how to do that in the next few days. Inertia is incredibly important in healthcare. I actually do remember when we were trying to get people to use dictation. It was incredible how many people insisted, no, I want to handwrite my charts, that they didn't want to move to dictation because it was primarily because it was new. Okay? And then when electronic health records came out, which I agree, incredibly inefficient, horrible user experience, there's all kinds of problems with it. But when we just put in place, so what we did in our group was we put out electronic discharge instructions first. Really simple. They were computerized, they were uniform, you could hit a button and they would all come out. And yet we couldn't even get anyone to use that. And that wasn't even any work. It was simply a matter of pressing a button, but people wanted to handwrite their discharge instructions still. And we said, well, there's more risk associated with that. You might miss things. There's a complete record here that you've provided discharge instructions. And yet, it took years. It took years. Like I said, we put in place a rapid medical. It took 10 years to get our physicians to see patients without being gowned if the patient had an ankle sprain. Now, we're a big group, but it took 10 years to do something like that. Why? Because physicians were like, well, no, my patients have to be totally gowned before I will see the patient. That was how it was for a long period of time. There is enormous amounts of inertia in healthcare, and it's cultural. So, will health tech innovation change healthcare? Absolutely. But remember, just like the dinosaurs, they lived for 165 million years before that happened. Okay? So yes, these things are coming. And finally, security and privacy issues that impact interoperability is an enormous barrier to healthcare. I'm not going to go into this at all because everyone is totally aware of this, and that is one reason that groups like Ping On actually can move so much faster. My only pet peeve is that we keep focusing on the banker. Okay, that's my only pet peeve. The whole country focuses on the healthcare system and what we need to do to improve security and privacy. There's not enough focus on the perpetrators of crime. We don't focus on the bank robber at all. We only seem to focus on the health system, the provider group, the people that are responsible for the record. Actually, the people that are taking the information are slowing down the adoption of technologies by a generation. The crime and punishment for those, to me, I think that should be much more severe. That's just a pet peeve of mine. But obviously, the whole security and privacy issue has a significant impact on our adoption of technologies. So, how do we get here? What are some of the solutions? I'm actually going to talk about how we move this adoption curve to the left, okay? I'm going to talk about three things intermixed: about understanding our customer, about consolidating and integrating to create programs, and about how we need to look at what it means to partner with our customers. So first, this is how people look at startup companies in health tech. There are thousands of them. Actually, I used this slide at a health innovation conference a couple years ago. It was a couple years ago. And at that time, I noted there were tens of thousands of apps in healthcare. Actually, we looked at it. There were over 250,000. 250,000 apps in healthcare. Well, that's insane. How can any reasonable person filter through all that information, all these types of things that are coming out in healthcare? Well, they can't. So what do you appear to be? For people with limited bandwidth, all of these innovations, to a large extent, appear to be noise because they don't know who's going to succeed, who's not going to succeed. And so all these things are coming at them, and a lot of it is just noise in the background. They don't have the time to focus on the types of technologies that many of you are creating to move healthcare. And we need to understand how they are perceiving us in terms of the innovations that we're creating. We need to assess our product as to whether it provides a comprehensive solution based on clinician responsibilities and system workflow. Okay? That's one of the things that we need to look at. When people have limited bandwidth, often we go to them and say, look how great our product is. Okay? But what we really need to do is look at how does it fit? How does it fit into the system that's in place? Not how great is our product, and if they only adopted it, wow, what a change it would make. But how does it already fit into the existing system? Here's my example. That frying pan there is probably better at frying eggs than any frying pan in the world. Wow, look at it. It makes a perfectly round egg. The yolk's in the center. How many of us fry eggs? Probably all of us. How many of us own a pan like that? Nobody. Nobody. Why? Because it doesn't fit into our workflow. What we're looking for is a pan that fits into our workflow that can be used in any situation. Okay? So I met, just a few weeks ago, a company that was doing machine interpretation of chest x-rays. For a radiologist, reading a chest x-ray is easier than frying an egg. Think about that. They don't want software that just looks at a chest x-ray and then they got to find someone else who has one that looks at long bones, one that looks at ultrasounds for gallbladders, one that looks at MRIs for heads, one that looks for PET scans. You know, what are they going to do? Put together all these different software packages to come up with that one comprehensive solution? If it's not a comprehensive solution, we need to evaluate how we combine with other complementary technologies in our space, whatever space we're in, okay? Because if we have what we think is an amazing product, it doesn't matter. It matters how it fits into the clinician workflow and the system that's in place already. It doesn't mean the product has to be complex. Maybe it does. Here's an example of a simple product stand on its own. It doesn't need to combine with anything, okay? Doesn't need any other technology. It works. However, look at something like this. You're a home health extender company, okay? You think you've got a great product. It's something that the whole community needs. Well, your product doesn't function unless you have communications in place. So you need to have a telecom system, some type of telemedicine component to this. Well, there are also patient algorithms that are out there that define for the clinician who should go to what type of environment when they're discharged. They can actually look at the world of outpatient opportunities. They can look at the patient and both the medical condition as well as their social factors and determine where they go. And you have patient navigator companies out there that are actually working with these patients. So you have home health extenders, telecommunications, patient navigator company, algorithms, and you need to combine them with the practice management support so you can link your primary care network with your skilled nursing facility, your hospice, your home health, your hospital personnel. Then that is a solution that you can go to a system with and say, look it, we have a product for dealing with your complex, comprehensive care management that impacts your readmission rates, that impacts how your patients do as an outpatient after they've been treated in a hospital setting. When you go with just one, so here, you can have that simple solution like that stethoscope and it stands on its own, but you need to look at your product and say, is it a great product? And is it a great product that already can just be put into a healthcare system that exists, or does it require significant manipulation and other components? Do I need to look at partnering with other companies to get this product into place? And here, this is incredibly important about understanding our customer. I think a lot of us recognize this as physicians. Anything that interrupts clinician workflow, requires an additional step, slows patient care, or disrupts current care processes will have a slower and less chance of adoption, regardless of the benefit. Regardless of the benefit. If we think we have a product that makes patient care better, but it doesn't fit into the current clinician workflow, we need to remember the system has been developed for 4,000 years, and the incentives are in place for clinicians to work a certain way right now. And we can say whatever we want, but everyone wants to have their day as efficient as possible so that they can generate the revenue they can under the system that currently exists. Nobody says, okay, I'm going to forsake my day or my revenue or my time to help your company put in place a technology that benefits patient care. Let me just give you some examples of things that you have to look at these types of technologies. You're an arrhythmia monitoring service. Well, if you have non-pushed data, you create clinician risk. So if you have data that you're collecting on patients that show, for example, a significant patient morbidity, and that data isn't pushed to the clinician, and the clinician doesn't pick up on it, you've created risk for that clinician. On the other hand, if you push data to the clinician and it interrupts their workflow, then they're pulled out of the care that they're giving, and that slows down their day. Seems like a no-win situation. Or these programs that optimize OR flow. We have companies come to us all the time, say, we can optimize OR flow. Can you present this to your anesthesia group? Actually, you know what? Many of our hospitals purposely leave ORs empty all the time. They want, because they have a neurosurgeon who brings in a reasonable chunk of change to that hospital. Exactly. And that neurosurgeon says, I don't care about your OR inefficiency. I care that, well, hell, I'm an important guy. When I come in, that OR has to be empty for me. Okay? And so then those software that we think, wow, this is great, look what we can do, doesn't fit into the system that's already in place and the incentives that are already in place for the healthcare system as it exists. So, what we need to do is understand how we partner with our customer and share risk. This is a quote from Robert Wachter. He's I think he's the chairman of internal medicine still here at UC San Francisco. He was the founder of the Society for Hospitalist Medicine years ago. What we need to do is build not just the digital tools, but also the workflow and processes. If patients are using a tool to manage their diabetes, there has to be a health system on the other side to make sure they get the care they need if they're not doing well. We need, as innovators, to partner with our health systems to actually not just provide the technology, but to look at how we're going to re-engineer the system to accommodate those types of technologies. Actually, over the years, because we are a large group, have visited with hundreds and hundreds of companies. Hundreds, thousands probably, I don't know how many. And they always come, and this is what they always say: we want to partner with you to sell you this technology. And I say to them, what does partner mean? And they say, well, we sell you this, and then you use it. And I'm thinking, how is that in any way partnering with me to do something? That's just selling me a product. Let me give you an example. We created, like I mentioned, we actually consult for state governments. Actually, we're doing it here in San Francisco with San Francisco General. We do it all over the place. We put in these comprehensive psychiatric programs. There's no more underbedded issue in the United States than emergency psychiatry. In the state of California, it takes between 2.5 and 3 days to place a patient from an emergency department into an inpatient facility. Here's the thing, 2/3 of those patients are discharged with no treatment whatsoever. They actually don't need any treatment. All they need to do is sit there and calm down, because a lot of them come to the emergency department, say they're suicidal, and they were just upset, and they're actually not. 2/3 of all inpatient psychiatric patients are discharged with no treatment whatsoever. And they wait 3 days for that to happen across the entire United States. Okay, so we created a telepsych program. We combined it with a crisis stabilization unit. We even staffed the inpatient psychiatry departments. Well, let me tell you what, it's not just a matter of creating that product, okay? We have to go, now as an intrapreneur, in a lot of ways, it's a lot easier, okay? That is one of the benefits, because we are in the system already, okay? So, but it still costs us on the order of 6 to 7 figures, not to create the product, to partner with our health systems to put it in place. So think about that, because it ends up being a win-win-win-win-win. The patient wins because they don't wait 3 days to be seen, they wait an hour and a half. The hospital, the emergency department wins because you see a patient on average every 3 hours. That's 8 patients a day. In 3 days, that's 24 patients that you've now been able to turn through that bed, because the bed is the production unit in an emergency department. The inpatient facility wins because now all the patients that are admitted truly need to be there. They're guaranteed reimbursement. They've eliminated all the unnecessary patient. The physician in the emergency department wins because they've significantly decreased the risk. The payers win because it's much lower cost. It's a win-win-win-win-win, and yet it takes 1 year to 2 years. There's no loser. And yet it takes 1 year to 2 years at least, and a lot of convincing, and a lot of initial resources to put a program like that into place. So think about that in terms of how are you going to partner with your health system, not the dollars that you spent to develop your product, the dollars that you need to spend as part of your business development to help re-engineer the way things are done. You need to allocate the resources, because why? because, like I said earlier, it's so hard to even figure out who the decision maker is. So you need to have the business development network so that you're reaching all the stakeholders, all the people that have power within the system. It's not just the decision makers, it's a lot of different people. In fact, how does a millennial know a call is spam? The phone rings. Yeah. That is how people look at healthcare innovators. Okay, remember, just the number of apps that are out there. So, what's some of the solutions? First of all, you don't need to have a 2 or 3 year horizon. You need to have a 10-year plan. You need to be a willing partner to invest with your customers in solutions. You need to recognize when your product is only a partial solution and combine with other companies that are creating likewise products. Wow. Sounds pretty daunting, huh? Sounds like there's going to take more dollars than a lot of us originally thought, and that's why a lot of companies don't make it in healthcare. There's so many that fall by the wayside that have truly great products. We're losing things every day, really great technology that never makes it out there. But, like I said, I am a total optimist. There are changes occurring in healthcare right now that are going to make it much easier for us, better for us. Okay? The first is there is enormous consolidation of delivery groups that will result in significantly greater risk tolerances and the ability to allocate resources to develop the system accommodations necessary for innovation. That is occurring right now at a phenomenal rate. The amount of consolidation that's occurring in healthcare, all of us are aware. What these much larger entities have now is the resources because they want to put in place new scalable solutions. And so what you're seeing is a significant amount of just consolidation and vertical integration occurring in healthcare. And these integrated systems are looking and they're much more willing because now when you're a single institution or a small group practice, you don't have the time or the resources or the effort availability to adopt new technologies. When you are a large system with significant resources at your disposal, all of a sudden that amount of risk that you have to take and invest to pilot and test new technologies becomes a much smaller part of your business. And now you can do that. The second, capital partners will result in the ability to accept risk and costs associated with piloting, adopting innovations. This is enormous. There's an estimated between $6 and $8 trillion of unfunded liability through pension plans in the United States. Well, who is one of the very largest investors in private equity? Pension plans. So you look at groups like a few months ago, maybe a lot of you saw Signify, which is a mobile physician group. It's the largest in the country. They have like 4,000 clinicians, mobile physicians. Bought Remedy, the largest convener for the CMS programs in the United States. Well, they also own Alteon, which is one of the largest acute care clinician organizations in the country. So Noon Mountain Capital owns all these groups. Well, they're a private equity company, and they just come in and they say, sure, Remedy's $600 million. We'll buy it. Why? Because they are interested in consolidating healthcare to create efficiencies so that their investment pays off. And so because of the amount of unfunded and pension plans, I don't know why, the stock market did phenomenal last year, but pension plans are still really high on decreasing their unfunded liability by investing in private equity, and these private equity firms are putting billions into healthcare. That means there is availability of dollars for people who are looking at taking on new technologies, creating the types of synergy that are necessary for future efficiency. Well, that bodes well for everyone in this room. And finally, large non-traditional players are creating healthcare verticals. We're all totally aware of this. They are looking at acquiring competencies to create complete comprehensive solutions. We actually provide Google with a significant amount of their clinician workforce. I can't say because Google's very private, but they did publish that AI-driven mastectomy. We provide actually their clinicians. That we do it for a variety of other things, but these companies are moving in an enormous way into healthcare. I'm sure a lot of you get the Wall Street Journal. This was yesterday's. Google will see you now. I just have a little quote here. Google has struck partnerships with some of the country's largest hospital systems and most renowned healthcare providers. And here's another portion of the article right here. 2 minutes? Okay. Don't worry about us making money. We're just investing. If we build it. No, that's what it says. If we build it, they will come. Okay? My point is, you have an opportunity to look at a different exit because these companies are taking enormous amounts of resources and capital and acquiring all types of different groups. What does that mean? Maybe you're not an entrepreneur. With all this consolidation and delivery, actually what it does is it creates a lot of intrapreneurial opportunities because maybe you're not your own company. Maybe you're part of some branch of Google or Amazon or Apple or one of these other companies, Microsoft, that is, and you want to look at that as a possible exit strategy, okay? Because here's the real thing that I believe is absolutely true. It's actually a heck of a lot more fun to ski than to sit on a big yacht. I don't know, I've actually never sat on a big yacht. But I can tell you, skiing's not bad. It's not bad. It's not bad to be an intrapreneur. I think what we're going to see is this is happening much more in healthcare, that a lot of the innovation that's occurring is actually going to occur on the intrapreneurial, not entrepreneurial level, and that there is going to be significant opportunity for you to look at how you create your product and develop it and get it to the marketplace. Am I done? I'm done. That's all I have. Thank you very much.